Good morning, councillors.
Hold on
We're not right. All right.
Yep, you're okay.
Good morning, councillors, officers, members of the public and press. Welcome to Adults and Community-Based Services Committee. This meeting is a remote meeting being live streamed and recorded. I will now hand over to Democratic Services team.
Good morning, Chair. Thank you. Good morning, members. I'll start this meeting this morning by way of a roll call of those present. If members could indicate that they are present and that they have the agenda papers for the meeting, please. I don't believe we have Councillor Brewer online. No. Councillor Little, yes.
Yes, and got the papers.
Thank you. Councillor Prince.
I'm here and I have the papers, thank you.
Thank you. Councillor Carl Richardson.
Yes, I've got everything, thank you.
Thank you. Councillor Thomas.
Yes to both.
Thank you. Councillor Ward. No. And Councillor Young. No. We also have Councillor Tony Richardson, who's joined the meeting as well this morning. So that can, are there any other members online that I haven't called? No? Okay, that concludes the roll call. I would just remind the usual reminder for people if they could keep their microphones on mute during the meeting, just to reduce the background noise on the for the meeting conference call for everyone and also on the recording. Thank you very much. Back to you, Chair.
Thank you, David. So we've done apologies for absence and those have been noted. Any declarations of interest by members?
Chair, my usual declaration as an employee of Healthwatch Hartlepool.
Carl Richardson.
And mine is, I've got my mother in an aged person's home as well.
Thank you, those will be noted. Can we receive the minutes and decisions that was held on the 23rd of October? Can we all agree to them? That's been circulated. Right, we'll go straight to, there's no key decisions. We'll go to 6.1, TSAB, Tees-wide Safeguarding Adults Board, and I think Jill's doing that presentation. And can we, I'd like to introduce Darren Best, who's the new independent chair of the board.
Thank you, Chair. Members will be familiar with the annual reports from TSAB that have regularly been to this committee. Previously, they were presented by Anne Baxter, who's been the chair of TSAB for a number of years. As Councillor Little just mentioned, Anne retired from her role recently, and we've been through a recruitment process and appointed Darren Best to undertake that role. Obviously, Darren's joining us today, but as the annual report relates to 2019-20 prior to his appointment, we felt it was more appropriate for me to present the report today. But obviously, Darren will be attending future meetings to present the reports. So in terms of the information that's presented to you today, it is a requirement that SABs produce an annual report, and it's part of the governance process of TSAB that we bring those to each of the relevant committees in the local authorities. So the report's attached to the agenda. You will see it's a similar format to last year. We received very positive feedback about that last year in terms of the report being accessible and a useful read for people. Just to assure members about our involvement in the board, obviously Hartlepool Council is represented on the board by myself and also by Councillor Little as the lead member. We do play an active role in the board. I chair the Safeguarding Adult Review subgroup of the board, and Neil Harrison also chairs the Communication and Engagement subgroup. So we do have a full and active part in the board. The annual report that's presented to you summarises the work of the board in 2019-20. Obviously, because of that timescale, it doesn't reflect any impact of COVID. That's something that we will potentially see and cover in the next annual report. But there are a number of examples throughout the report of initiatives that are happening in each of the local authority areas. So, for example, in the Hartlepool elements, we talk about the team around the individual approach. That's a multi-agency approach that we introduced in response to a safeguarding adult review a number of years ago, which has now been rolled out and adopted across the Tees area and is working well. There's been a particular focus on areas around self-neglect and modern slavery over the last year, which are both referenced in the report, and one published safeguarding adult review, which again is summarised on page 15 of the report. So I don't propose to go through it in any more detail. Obviously, members have had the opportunity to review the report, so happy to take any questions. And also, if Darren would like the opportunity to just say a few words to introduce himself, then I'll hand over to Darren.
Morning, everyone. Yeah, well, thank you for inviting me, and thanks to Jill for presenting the report on this occasion. I do know some people that are on the call, but for anyone who doesn't know me, my background prior to becoming chair of TSAB was largely in policing. I was a police officer for 30 years, 26 years of which was in Cleveland Police, and I've worked Hartlepool both as a sergeant, as an inspector, and then later on in force-wide roles. But my last 4 years in policing, I moved to Northumbria Police, so covering Newcastle, Sunderland, all the way up to the Scottish borders. And my last role there was I was Deputy Chief Constable in that force. Since leaving policing, I took up a role as a non-exec director with Cumbria, Northumberland, Tyne and Wear NHS Trust, which is a mental health trust, and I continue in that role. So I applied for TSAB. I've got a long history with safeguarding services throughout my policing career, and it obviously complements the work that I'm doing as a non-exec director. I have sent a letter out a little while ago to members of the board just to introduce myself, to save some time at the board, but it gives a little bit more detail about me. But probably more importantly, just to confirm, I've been in post now as the chair since the 22nd of October when I took over for Anne. It's quite clear to me that Anne's done a great job, and my view is that safeguarding adults work is in a good place in Teesside. But to confirm what Jill said, really Hartlepool as an individual area plays a very active part in that ward, Jill herself, but others as well, and certainly in the early days of my being in this role, I've had nothing but help, cooperation and good advice from people in Hartlepool. I think the only final thing for me to say is that the next year's annual report will be written quite soon, and we're actually in March, we're going to have a development day in which we will set the priorities for 2021-22, which is kind of the next year on again. So this is almost 2 years behind this report now, but it's just obviously the nature of when things are produced and when they're presented. But I'll be really interested to hear people's views about what they think those priorities should be moving forward. So thank you, Chair.
Thank you, Darren. I'm sure it would help you try and prioritise some things from our lovely committee here. Steve Thomas.
Thank you, Chair. And firstly, welcome Darren to his first meeting of the Adult and Community-Based Service Committee. And I'd just like to echo what Darren said with regard to Anne, your predecessor. I think that she did a fantastic job of raising the profile of adult safeguarding within the Tees Valley area, and really got it onto the agenda of lots of organisations and into lots of areas where it perhaps hadn't had that sort of profile and priority in the past. So I do think we need to record our thanks to Anne for her work and the support that she gave the committee over a number of years. I think that it's an excellent report, and lots and lots of information in there. But I think it has become quite sort of historic with what's been happening over the last 9 months or so with regard to COVID. But I think there are a couple of areas to perhaps focus in on. And I think one of the first ones is the trend with regard to Section 42 referrals, and DoLS is still showing that upward trajectory, which has been there for a number of years, and we have had discussions at the committee around that in the past, and realise and understand how that is linked into the requirements of the Care Act. And I think once again, I would flag up, yes, I think it is important that those concerns come through, but there certainly is an ongoing cost to the local authority, which the government seems reluctant to acknowledge and meet. And once again, I think we've had indications from the government in the recent past that they will not be doing anything to address that issue, which I think is quite a sad thing. I think another thing for me was I was very interested reading the case review that is in the report. And I think it's really important that that sort of thing continues in future annual reports, and that the learning from such cases is integrated into practice going forward. And I think one thing for me, which it sort of like brought to mind, was the case that we had in Hartlepool, the very sad case that we had in Hartlepool in the not too distant past, which went under the name of Carol. I'm sure that people on the committee know the individual involved in that case and know the circumstances. And I think it's not just the immediate cases that we need to be focusing on, as I think there was an awful lot of learning that came from the Carol case. And I think it really highlighted some of the issues around adults such as Carol, who have very chaotic lifestyles, who have dual diagnosis issues around underlying mental health issues, either alcohol or drug misuse, and the vulnerability that such adults have within their lives. And I just think that perhaps sort of like an update of some of the learning and some of the developments and some of the changes in practice would be useful for the committee from that case. And not necessarily asking you for that, Darren, but maybe Neil or someone could, or Jill could update on some of the changes in practice that have come about within Hartlepool as a result of that serious case review that took place a few years ago, which I'm sure members remember very well. I think one or two other things that have come through during the pandemic have been issues around scams and the way in which vulnerable adults across the Tees Valley and nationally have been quite ruthlessly and horribly targeted by scammers, and an update on some of the work that's happening around scams and getting some of the messages out around being aware of how some of these scams operate, particularly the online ones, as we have had some instances in Hartlepool where elderly people have lost life savings because of these scams, and in some instances tens, if not hundreds of thousands of pounds. And I think the other thing which really comes through is some of the issues around domestic violence, which are starting to come through. And again, it's not necessarily the historic information, but some of the work that's happening locally around that issue going forward. So quite a little package of things there. And as I said, Darren, I know you were very new, so I wouldn't expect you to be able to go into detail on all of those, but certainly some updates around those issues would be useful for the committee, I think.
Sorry, my mum was ringing me. Jill, do you want to come back on that?
Yep, thank you, Stephen. I think some really valuable points there. We certainly had a discussion at the recent board meeting, and we've discussed through the SAR subgroup how we capture the learning that's happened in response to some of these cases. As you say, some particularly tragic cases, and one of those in Hartlepool that was very high profile. And we do provide updates to the board in terms of the learning from those cases. And certainly the Carroll case in particular, that did prompt some significant changes in practice. So that was the case that led to the work around the team around the individual approach, which we've just recently audited, both in terms of the number of cases that we've been seeing through that process, but also how partners view that process. And that was very positive. That was an initiative that we developed in Hartlepool that's now been adopted across all 4 of the Tees local authorities. And we continue to review that because it is a time and resource intensive process. So it does produce good outcomes, but we do have concerns about the number of people that we can actually feasibly support through that process within existing resources. We do see some common themes coming through the SAR review group, so from safeguarding adult reviews and from lessons learned reviews. There are some common themes around substance misuse in particular that you mentioned, also domestic violence and some of those cases where people have dual diagnosis issues. And what we've recognised is that we need to approach that maybe a bit differently, that we do need to work more closely with the local safeguarding children's boards and the community safety partnerships, so the Safer Hartlepool partnership for ourselves. And we do have plans in place to get people together to look at how we can work more collaboratively across those partnerships specifically for Hartlepool. So that's something that myself and Darren discussed recently, and we've got a meeting being arranged in January with the chairs of each of those other partnerships to look at how we do that going forward. And just the other point to mention, you mentioned in particular there scams and the risk of financial abuse. And that's something, again, that we've done a significant amount of work on. And we do have very good working relationships in Hartlepool between the Adult Services Department and the Trading Standards team in particular. So we've done specific pieces of work with them around support for people who are targeted by cold callers and some of the doorstep scams. And again, some of that has then been picked up by other areas across Tees. So I think there's still more to do, and there are some particular, as you said, some particular COVID-related scams, and we have promoted information about those to people, but it has brought out some of those particular challenges. So we have got positive relationships there to build on, but yeah, that's certainly something that we'll need to pick up going forward. But if it's helpful for a future meeting of the committee, we can certainly pick up specifically that issue around the learning from some of the reviews, because that's something I know Darren mentioned in his role, new to the chairing role, that he would like to see coming back to the Tees Safeguarding Adults Board as well. So we can certainly share that.
Thank you, Jill. Darren, would you like to come and add to that?
I won't take too much time, Chair, because Jill's covered just about everything that I was going to say, but just in response to Steve, really, that from my perspective, it's really good to hear the things that he's pulling out as being relevant issues, but that's important, I think, for me to hear. And the good news is there's nothing that Steve said there that I don't entirely agree with in terms of what the priority should be. A lot of them, as Jill's already said, even in the early days of my role here, we've had some discussions around them. But I think that the key one that I would probably really draw out is that relationship and that needs to be built between community safety partnerships, health and wellbeing boards and children's partnerships with the adult, because a lot of these families, and I'm very familiar with the Carroll case, it was one of the last incidents, if you like, I was involved in before I left Cleveland Police, so I'm aware of it. But it's that sort of holistic approach where the people that we engage with and encounter and try to safeguard tend to be involved in lots of different groups and cut across services. So it's important that those services are talking to each other and where necessary have joined up protocols, procedures, whatever it takes, really. So I won't say more than that, but I'm really grateful for the heads up on what's important to you.
Thank you. Carl, would you like to come in now?
First of all, I'd like to welcome Darren to the meeting. I think you'll find it very interesting. I've just got some questions, that's all. It's a very good report in the sense of a lot of information there. On page 4, where we talk about types of adult abuse, and it's good to see that there's been a reduction of 34%. However, I just wonder, is that because of COVID? Because we know, or we have an idea that there's been a lot of abuse, but it's not always reported because of the COVID situation. I don't know if you'd like make any comment on that, Darren or Jill. The other thing is it possible to have this to be based on a local authority, the statistics? Could we sort of get that out, what the situation is in Hartlepool in particular, obviously, but also the other authorities, so we can compare notes? That's on page 4. There was another one just on there was some information as regards Redcar Cleveland, and I know it's not Hartlepool. However, there was a major problem where the people on this is on page 10, where the people behind this, were they apprehended eventually, or do we not have any information on that? It's on page 10, and on just on the back page, Appendix 1, 18, it seems to be, especially as regards dolls, on 2017-18, we had 1,316 referrals. Middlesbrough only had 728, and they have a bigger population. There seems to be a real discrepancy there. Could anybody make any comments on that as well? That's on page 18, Appendix 1.
Jill, would you like to come back on that?
Yep, so in relation to the issue on page 4, where it talks about a 34% reduction in section 42 enquiries, that specifically relates to incidents in care homes between residents. So historically, there has been a high number of referrals related to that, and it's largely relates to people with dementia and people who lack capacity, who potentially can be quite disruptive in the care homes and cause incidents. We have done some specific work with care homes to be more proactive in how some of those challenging behaviours are managed, and that's what's led to that reduction. So that's a positive reduction. The overall section 42 enquiries actually increased in the year by 37%, which is what's highlighted at the top of the page. What we don't have yet reflected in this report is any impact related to COVID, because this report runs up to the 31st of March this year, and obviously we didn't start seeing the impact of COVID until around that time. So it will be in the next annual report that any COVID related issues are picked up. Just in terms of the breakdown of the statistics by local authority, obviously all of that information is available. It's presented to the TSAB on a quarterly basis. So that obviously can be shared. That's public information that's available on the TSAB website, but we can circulate links to that to members if that's helpful. On page 10, which talks about the cyber attack on Redcar, I'm afraid that's not something I can comment on. I don't know what the position with that is. I do know it caused significant challenges for Redcar and Cleveland, for adult services and across the wider authority, and the timing of that linked to the COVID impact was a particular challenge, but I'm afraid, as I said, it's not something that I've got any further information on. In terms of the dolls referrals, which are referred to on page 18, from a Hartlepool perspective, I can say that we were very proactive in terms of how we worked with the care homes, in particular in Hartlepool. Our team went out, met with each of the care homes to talk through the dolls process. So I think what happened in Hartlepool was we saw higher numbers earlier in the process in terms of dolls referrals, because we'd taken that very proactive approach. The numbers do continue to increase because people have an annual review of their dolls, and there's obviously new cases as well. So we've got a very good understanding of the picture in Hartlepool. I'm not sure why the figure in Middlesbrough, particularly for that year, was lower, but it was very much about the local approach to dolls, I suspect, and how their care homes operated. And as I said, we did do lots of proactive work with our care homes and continue to support them in terms of making dolls referrals. So I suspect that's why our numbers are a bit higher than you might expect in terms of the population size. Hope that's helpful.
Thank you, Jill. Darren, do you want to say anything on what I've asked?
Yeah. I mean, I can't answer the question in relation to the cyber attack similar with Jill. I guess the point I was going to make was a wider point around performance information. And obviously you picked up on some of the figures there, and looking for specific information for Hartlepool quite rightly and quite understandably, and certainly from my perspective, although the board, if you like, is a Tees-wide board, I'm very interested in what's happening in each local authority area, because I'm conscious that the 4 local authorities in Teesside, albeit geographically we share the same territory, if you like, but very, very different in terms of the areas and in terms of the local issues, that they're not the same. And I can say that, having worked up in Northumbria and Newcastle and Sunderland, they're not the same either. So it's important that we remember the individuality, if you like, of each local authority area. But I suppose for me, the performance information, and I chaired my first board last week, we didn't pay enough attention to the performance information in my view, and I think I said that we didn't have enough time actually. So I've asked for that to be moved higher up the agenda, but how we interpret and what questions follow from performance information, having been involved in it certainly quite heavily for the last 20 years, is really important. And I don't necessarily see, and I know you didn't say that whether it was a good thing or a bad thing in terms of Middlesbrough being higher than Hartlepool. The simple fact is we don't really know if it's a good thing. As Jill said, that could indicate proactivity in Hartlepool, it could indicate an issue in Middlesbrough or vice versa. But my instinct on it is that things are well and good in Hartlepool, and you have got a grip on what's going on, and so your performance information appears to be pretty reliable. It's what we then do with it, I think, is the important thing. And I think I said last week at the board that a lot of work goes into producing performance information, a lot of officer time within your authority and the others. But the question that we need to continue asking ourselves is the so what? So those numbers are there, so what are we doing about that? What does that mean? Where do we need to put extra effort? Where do we potentially need to put less effort? And that's certainly something I'm very alive to. So to hear from yourself, Carl, you're picking up on some of those performance issues is, again, good for me to hear as well, that that's important too.
Thank you very much.
Thank you there, Dan. Any more questions before I go on then, Darren? Are you putting your hand back up there, Darren? No, right. I think we are blessed to have TSAP as and how closely all the organisations work together, because all the organisations are talking together, they sit around a table, and I think that is so important that we learn from each other, and hopefully we'll never have the Carols or the Josh's cases ever again. That's obviously my greatest wish, for that to happen. And I think the points that you've brought on about financial, the financial side where people are getting scammed and stuff, that is so important, because it's so easy. You get, how many calls do we get from press 1, you're going to go to prison? If you don't, press number 4 from HMRC. There's lots and lots of different type of scams going out there, and I think for us to highlight them, and hopefully we'll take this to the board and we'll start doing work on it to stop these people scamming our elderly and our most vulnerable people in the society. Carl, do you want to come back there, or is it a historical hand? No, it's a historical one, right. Darren, you're more than welcome to stay to listen to the rest of the committee. But if you've got to run off, you can, by all means, you can run off or you can stay. It's entirely up to you. But welcome to, hopefully next time you'll be able to have a nice proper cup of tea from Hartlepool. And we'll be sat around our committee room. I can't wait for those days to happen again, because the buzz is completely different to what you have over Teams, even though Teams has kept us going for a long time. But the committee room is a lot better, and I do prefer it a lot more. But it's entirely up to you.
Thanks for your welcome, Chair. And if it's all right, I mean, sometimes I probably will buzz off. But just looking at the items that you've got left on your agenda, I'll just sit in the background and listen if that's all right. Some really interesting stuff there. So if that's all right, I'll stay.
No, thank you. That's like really nice to hear. Thank you very much. And obviously you can comment if you want.
Oh, thank you.
Right. I think we're having the care home update, and I think Trevor's going to be presenting this.
Yeah, thank you, Chair, and good morning, everybody. The purpose of this report is to provide Adult and Community-Based Services Committee with an update in relation to care home provision for older people, and particularly some of the effects of COVID in Hartlepool. The background to this is there's been regular updates to the committee for a number of years related to occupancy levels, quality assurance, and the support of the care home market. The current position, of course, particularly since the last report in February 2020, there have been a number of developments, and the main one of those being the effects of the COVID crisis. So just going through some of the details, the care home capacity in Hartlepool, there are a number of older people living in care homes that has dropped significantly in the summer of 2020 due to the increased rate of deaths from COVID, although the figures now show that that is starting to recover and getting back to pre-COVID levels. And there's detail in that in Appendix A, Table A, sorry, Appendix 1. And that generally shows the number of people in residential and care, nursing care is getting back to the levels it was. And from that, the number of people who were over 85 remains fairly consistent. There are about 754 registered care home beds in Hartlepool for older people. That includes both residential and nursing care. And the total number of vacancies in these older people's care homes did increase significantly, as we'd mentioned, to a maximum of about 111 in sort of June. And again, that information is in the appendix. That was an average occupancy of around 85%, but that has recovered now. So occupancy now is about 92%. The number of out-of-borough placements has reduced over the last year and has continued to reduce since the COVID-19 outbreak. And again, there's details of those numbers in Appendix 1, Table B. COVID-19 has had a massive effect on the most vulnerable people in our society, and tragically, the impact has been felt particularly in care homes, probably more than any other areas. And Table D in Appendix 1 shows the high number of COVID-19 cases in care homes in Hartlepool, and particularly from April to June was where the bigger numbers occurred, with a smaller number of cases in the following quarter, as you would expect. But cases are increasing again in line with the prevalence across the borough. The number of deaths in care homes, again, the detail is shown in Table E of Appendix 1, has increased significantly in the quarter ending the 30th of June. The additional numbers of deaths when compared to earlier quarters is clearly related to the COVID impact, with 53 deaths directly attributed to care homes, COVID in care homes, in the last 8-month period. In terms of PPE or personal protective equipment, in the early stage of the pandemic, care homes experienced significant challenges accessing PPE, and this was resolved by adults and community-based services with significant stocks and support to care homes if they needed it, and a number of care homes did make use of that. And the council also receives a weekly delivery of PPE, which can be used to support care homes and other providers on an ongoing basis. So we're still doing that now, but to a lesser extent. We also had COVID premium payments in recognition of the financial impact of the pandemic. And the council provided COVID payments to care homes from March 2020. And originally that was set at 5%, so 5% premium added on. That increased to 10% towards the end of April. It went back down to 5% in August, reduced to 2.5% in October. And now from November, the beginning of November, those premium payments have ceased. Payments were reduced and then removed in line with national developments, including the provision of PPE, no cost to care homes, and that's been a consistent approach across the North East region. In terms of Infection Control Fund, that was a grant paid to councils from central government to support adult social care providers with a particular emphasis on infection and prevention control. And it was directly passport to the majority of grant allocations to care providers. with a small proportion identified for allocation to meet local priorities. The initial funding was approximately £962 per care home bed. So, for example, if a care home had 10 beds, they would have received a one-off amount of £9,620. There was a further 92,000 that was paid allocated to support additional infection control measures, and that was things like safe visiting and other elements as well across care homes. There was a second small allocation of the Infection Control Fund in October 2020, and that was or amounted to approximately £663 per registered bed, so not as much as in the first tranche, but still a significant amount. And a further 586k has been distributed to date, with a further payment to be made for the remainder of this financial year. Care homes provide monthly returns that outline how the grant has been spent, so we have that information because we do need to do a return to central government. The initial guidance indicated that infection control, this grant particularly, should fund a number of measures, and they included staff who are isolating, so making sure that they get paid normal wages, ensuring as far as we can do that members of staff only work in one care home, and also limitations to things like the use of public transport, etc. The guidance was updated for the second funding allocation and included additional elements which were very much around supporting safe visiting in care homes, such as dedicated staff to support and facilitate visits, additional cleaning and various other measures, and also ensuring that staff who need to attend work for the purpose of being tested are paid their usual wages to do so. In terms of support directly to care homes, throughout the crisis, the Adults Commissioning Team has continued to support every care home in the town with information, advice and guidance. And support has also been provided by another set of people and organisations, particularly environmental health officers within the council, public health, health and safety teams, the Infection and Prevention Control Team, which includes the IPC nurse, community matrons, and the CCG or Clinical Commissioning Group. At the peak of the COVID-19 crisis, the Adults Commissioning Team was in daily contact with all care homes in the town, but this is now reduced to twice per week, but regular contact as and when required is also important. In line with the requirement of the Adult Social Care Winter Plan, a weekly update is being sent to care providers from the Director of Adult Social Services and the Director of Public Health, and the first two updates have been included in the Appendix 2 and 3. Excuse me. In terms of the management of outbreaks, an outbreak is classed as 2 or more positive confirmed cases affecting either residents or staff in a care home. And as of the 16th of November, there were 13 care homes that had outbreak plans in place. All care settings experience outbreaks are actively supported by the Adults Commissioning Team, Public Health, Environmental Health Officers, as well as receiving targeted support where required from other agencies, including Public Health England and other organisations. Weekly meetings take place with all agencies and the care home concerned to support the management of that outbreak. So specific teams are set up to manage outbreaks where required. In terms of testing, whole home testing is now in place in care homes with staff tested every week and residents tested on a monthly basis, which allows asymptomatic staff or residents to be identified as well as those with symptoms. In terms of quality assurance, 92% of all care homes in Hartlepool are currently rated as good by the Care Quality Commission or CQC, and there's details of that in Table G of Appendix 1. 15 of the 16 care homes for older people are rated as good, which is 94%, with only one home requiring improvement. Lost my page there. Oh, sorry, I beg your pardon, lost my page. It's a major improvement, 75% rated as good in March 2019, and demonstrates the continued commitment from providers, the council and its agencies to drive up quality in care homes. There are no homes where, currently there are no homes where there are suspensions and new admissions in place. In terms of care home visiting, when the first national lockdown was implemented in March 2020, all non-essential care home visiting ceased, with the exception of the end-of-life visits. Care homes facilitated contact between residents and families where possible using phone calls, video calls, and there was things like window visits where the person was physically outside the home. Some homes have reintroduced COVID secure visit in the summer months as lockdown measures were eased, but this was limited in order to protect, obviously, the people who were residents in that home, as well as stopping the virus spreading. In September 2020, further national guidance was issued and care homes in Hartlepool were advised that all non-essential visiting should be suspended at that point in time. Work is currently underway to explore how non-essential care home visiting can be reintroduced safely by using the new lateral flow tests and how that would include testing visitors to the care homes. And details can be found in the newsletters in Appendix 2 and 3. In terms of risk, there have obviously been concerns in recent years about the availability of sufficient care home places for older people in the town, but this risk is reduced since the lifting of suspension admissions at one of the homes, and current capacity was meeting the need prior to the COVID pandemic. This continues to be the case. However, COVID outbreaks do have a significant impact on admissions. Pressures on care homes and staffing levels due to staff being absent, self-isolating are also significant, and staffing levels and reliance on agency staff are being monitored regularly so that we know the current position on that. Any reduction in care home capacity would increase the need for older people to access out-of-area placements, which, as we've mentioned earlier, has been reduced over the previous months to minimise movement of staff between care homes. Reduction in care home capacity would increase the need for older people. I'm repeating myself there, beg your pardon. New national requirements for local authorities in partnership with CCGs around designated settings came into force in 2020. A designated setting allows people to be discharged who are COVID positive. No care homes in Hartlepool are currently able to deliver the requirements to meet that designated setting requirement, but we are continuing to work on different options with our partner organisations, including health across the area. Moving on to financial considerations, there are significant financial considerations associated with care home provision, including the fair cost of care and the implementation of the national living wage. And information in relation to additional payments we've already mentioned, which is included in section 4. Legal considerations, the care home provision for older people supports the council to fulfil its statutory duties in relation to the provision of adult social care in line with the Care Act. And there are no other legal implications associated with this report. There are no consultation considerations associated with this report, no child and family poverty considerations, no equality and diversity considerations, and no staffing considerations associated with this report, as well as no asset management. So it's the recommendation that the Adult and Community-Based Services Committee note the content of this report and receive a further update in 6 months. And the committee has also identified care home provision for older people as a priority due to the role of care homes. And I think there I rest if I can, Chair.
Thank you, Trevor. That was quite intense. Carl, would you like to come in?
Yes, I'm very interested in the weekly update for Hartlepool Care. That's very informative, that. And I don't know if it's possible. I don't know if you're still doing it, because we've only got 2 weekly updates at the moment. But I'd like to see is that possible for committee members to get these reports? I think it would be a good idea if that happened. Just referring to one of them when we were talking about access, and I'll read what it says here. It says, unfortunately, I hope the printing will be a bit better. If you look at the weakness, the printing is not all that good, really. So it says, as regards care home visiting, we advised in last week's bulletin, we have been busy exploring ways to support care homes to restart non-essential visiting, and we're pleased to find out that this week that Hartlepool is one of the local authorities nationally that will receive a weekly allocation of lateral, not too sure it's tests anyway, a new test that can be done and frequently on site with results available within 30 or 40 minutes. Now, I know one home at least where that doesn't seem to have happened, and this was dated on the 4th of November. can I ask how many other homes where has this been implemented in Hartlepool? Do we know? Do we have that information?
Jill will, hopefully.
Oh.
Jill?
Yep, so in terms of the weekly updates, yes, they continue. We've just sent one out yesterday, I think it was. The last one for this year will go out next week, so there's no problem with those being shared. They can be shared electronically, and they are much easier to read when you see them electronically. I hadn't seen one printed out till I've seen them in these appendices. So, yeah, myself and Craig continue to provide those updates to care homes every week. In terms of the lateral flow tests for care homes, I think just to put a bit of a caveat on this, it's been a very much a change in picture for us over the last few weeks. The guidance has been changing on pretty much a weekly basis, sometimes a daily basis. So it's been very difficult to keep up with this and to keep the care homes informed of what's happening. We originally applied to be part of a pilot where we could use the lateral flow tests with care homes. That was then overtaken by a national announcement that actually there would be a national programme to support this. So it was delayed a number of weeks because it was taken over as part of a national programme. The tests are being rolled out to care homes. Initially, it was based on the largest care homes nationally, so a small number, I think it was 3 Hartlepool care homes initially received the tests. And it's not clear yet when it will be rolled out to all care homes. I think I just want to say there, though, that it's not as simple as it sounds, that these lateral flow tests will allow care home visiting. In order to use these tests for visiting, care homes have to have trained staff. They have to be able to identify appropriate waiting areas in the care homes. They have to identify appropriate visiting environments. So there are some care homes that will find it very challenging to introduce visiting, even with the use of the lateral flow tests. There are also some concerns about care homes that have outbreaks. So if a care home has an outbreak, which could mean that 2 staff have tested positive, for example, there can't be any care home visiting while that outbreak's current. So it's a lot more complicated than it sounds. And I have to say, some of the national messages about everybody being able to visit care homes again before Christmas, or the messages around people being able to hug their relatives before Christmas have actually been really unhelpful from our perspective, because actually that's not necessarily the reality for lots of care homes. So we're working very closely, Trevor's team in particular, working very closely with each of the care homes to understand what they can do within their own environment and their own staffing resources to be able to introduce visiting again. We know it's incredibly important for both for the care home residents and for family members to be able to visit their relatives as soon as possible. But obviously our highest priority is that we do that very safely and in a way that protects our most vulnerable residents. So it's really important that we take the time to get this right.
Yeah, I understand where Jill's coming from, and I have no criticism locally whatsoever. I know it's very difficult because the government seems to be changing its position and saying things which are not, in actual fact, completely true. But could I ask how many homes have actually implemented it so far in Hartlepool, or haven't any done it yet? That was my question, really. Is how many actually, how many have implemented this so far?
Jill, do you want to come back on that? You've gone. Yeah, you've put your hand down.
Can I just answer that question?
Yeah.
We're actually working with the homes now to do it. So we're in that process as we speak. The thing I would just say is that the homes all have different setups. They have different layouts in the homes. So it's almost a bespoke model for every home that we're working with. So we're doing that as we speak now.
Right. Well, sorry, could I just ask then, how many do you think we'll have before Christmas? Because obviously we'll come up to Christmas, people are getting desperate. They haven't seen their loved ones since March. Excuse me.
Just in terms of the current process, we can be working with a home, and then if there's an outbreak at that home, then they would have probably started to do visiting, but actually that then stops because the outbreak then stops it. And we do have outbreaks, because it's only 2 people, either residents or staff. We do have outbreaks at a number of homes, so it's a fluid position all of the time. There isn't a set position, because tomorrow there could be an outbreak at a home which would actually stop that going ahead, which could be ready for Monday or Tuesday of next week. Does that make sense? Does that answer your question?
I just think this time of the year, especially when everybody wants to be with the parents, and there's so many of our residents in Hartlepool who have just so desperately to go up to the mum or the dad or the nana or the granddad and give them a cuddle. This year we've never experienced a Christmas like it, and we've never experienced a pandemic. And to find out, like, we might be clear to go and do a home and start the testing for residents to go in, for family members to go and see their loved ones, but on that morning they could get a positive test, and it totally puts a stop to everything for another fortnight. I think the homes, they keep on posting things on Facebook and stuff, and I know it's not good, and I know people are so dying to touch their family members, because God, that hurts me more than anything. And but not being able to, this pandemic has got a lot to answer for. And I tell you what, when the injections are going out now, we're going to get the injections in the homes, and then we're going to stick 2 fingers up to COVID. And I'm sorry that we're streaming, but that's the way I feel about COVID. We're going to stamp it out left, right, and centre, and we're going to win this battle. And we can just have the biggest party in Hartlepool's ever seen across the world, and that's what hopefully I hope to see in the future. Jill, do you want to come back and say anything extra?
Yeah, it was just to say, as Trevor said, some of the homes are in a position to start offering visiting, but it is a position that could change daily. So it's really difficult to say. I think there'll be a very small number of care homes that can actually introduce visiting in the next week or so, and it will be very limited in terms of the number of visits that they can allow. I suppose, again, just to reassure members, we're just this week, as well as the communications to care homes, we are sending a letter out this week to family members and friends of people who are living in care homes, just to explain the situation to them, because there are the national messages, and we just need to be really clear with people that this is not in any way whatsoever us trying to stop people visiting care homes or wanting to restrict that. We do have to follow the national guidance, and we have to be really assured that any visiting is implemented in a very, very safe way. I think what would be incredibly distressing for everyone is if after such a long time of living under the restrictions, we ease them too quickly and then actually have a horrendous impact in terms of our most vulnerable older people. So we are working very closely with the care homes, as Trevor said. We do recognise how difficult it is for people, which is why we're writing directly to family members and friends. And those letters will be going out via the care homes this week. So we will obviously keep people up to date. But as I said, it's an incredibly difficult issue to keep up to date with. The real thing that we want to prioritise with the care homes, and Councillor Little just mentioned it, is the vaccination is actually going to have a far greater impact for everybody than using the lateral flow test. So the real thing that we want to prioritise, and we're working very closely with our NHS colleagues on, is making sure that all of our care home staff and residents can have the vaccine as soon as possible. On a really positive note, some care home staff from Hartlepool have already been vaccinated. That started last week, and we're doing everything we can to roll that out. Once all of the staff and residents in a care home have been vaccinated, obviously that has a massive impact in terms of visiting and how the care home can operate. And we are seeing that. So hopefully over the next few weeks, recognising that the vaccine takes some time to be fully active, hopefully that's something that within the next couple of months will be the sort of game changer in terms of care homes and visiting. And that's what we're trying to promote with our care homes.
Thank you, Jill. Trevor, do you want to add to that as well? Or
Yes, if I could just add one point. The vaccination programme started last Tuesday, I think it was, for staff in some care homes, in the larger care homes, which was obviously Health ran and is based out of James Cook Hospital. And if somebody was vaccinated with the first vaccination on the 8th or 9th of December, it's 21 days after that that they need to get the second vaccination, and the person then in theory should be immune a further 7 days after that. So what that tends to say is it's literally 4 weeks after your first vaccination that you would become hopefully immune from that. And the second point I would just mention in terms of the visiting and the what the homes can and can't do, ultimately is the home's choice. They have that decision because they are private independent companies. But obviously most of the homes, all of the time, generally will follow the guidance which is given both nationally and locally, although sometimes the national guidance is a little bit woolly.
They keep on changing the goalposts all the time, as we all know. Stephen, would you like to come in? You're on mute, Stephen.
I think the first thing I'd like to say is to thank Trevor and his team for the work that they've done during the pandemic. And I think to also thank our care providers in Hartlepool, who I think under some very, very difficult circumstances have continued to work really hard, have really stepped up to the plate with regard to what was needed during the pandemic. And it's been a very difficult time for everyone concerned, whether it be council staff, care providers, families, residents. But I think we've been extremely fortunate in Hartlepool in that I think, as Jill said earlier, we have got some very good care providers. We have got some very strong relationships between the local authority and our care sector. And they have really borne fruit. Those relationships have really come to the fore, I think, during the pandemic, and have been really a really big help in ensuring that the best possible care has been provided to people during these very, very difficult circumstances. I think one thing that sort of like really struck me is the discussion that we've had around contact with residents, and that break in contact that residents have had with their families. And I think that's clearly bound to have had an impact on the mental health and well-being of our care home residents. And I think the other thing that's probably compounded that is it's undoubtedly been much more difficult to have the same sort of activities, outings, and other things that our care home residents regularly experience happening during the pandemic. And just one thing I'd be interested in hearing about from Trevor is the sort of things that the homes have been doing to try and support the mental well-being of residents, and also under very changed and difficult circumstances still to provide that sort of those activities and inputs that are so helpful to residents with regard to their both physical and mental well-being.
Trevor, would you like to respond?
Yes, please. Yeah, good question. Thank you. I think all of the homes have tried to engage with people in different ways, because in many instances, people are actually isolated in the rooms if there's outbreaks in homes, which is very, very challenging. So I think what the homes have tried to do is engage with people in different ways. And often that can be technology based. It can be telephone calls with people. It can be trying to do things in a different way so people are socially distanced. I know, without mentioning the name of any particular one home, a home in Hartlepool that has a lot of activities on, and initially they found that quite difficult because it was a home where they did all sort of chip in and sort of engage with each other at very close quarters. And what they found was they had to then limit the number of people in rooms, have them socially distanced, etc. So they could still do some things at certain points, but they were done in a very different way. I think because people have not been able to see their relatives very much, what the homes have tried to do is enable things like window visits. And that's where the person is outside, and obviously the resident is inside. But because the window can't be opened, there can still be sort of a phone call. So the phone can be both inside and outside with a mobile, where you can still speak to your relative and see them at the same time. So they have had to have been innovative in their approach. I think it has been challenging. And I think, again, probably most of the homes within the town have tried to do things which have engaged people and got them to be doing as much as they possibly can do. There has been very clearly restrictions that that have been put in place. So people who often want to go out of the home, that, you know, people might still want to go out of the home. And for some of the LD homes, that still happens where people do need to go out. But for example, it might be that there's a minibus which normally would have took 3 or 4 people, but actually now that has to be one person at a time. There's a distance involved, etc. So it's been more challenging, but some of those things have still happened.
Stephen, do you want to come back on that?
Yeah, I think it's really heartening to hear that the homes have been so proactive around those sorts of activities, Trevor, because I think they are so fundamental to keeping people well and in very difficult circumstances, giving people at least little things to look forward to in their daily and weekly routines. And I think keeping people active is so important as well, because I think for a lot of residents, that is so important, because if they lose sort of little activities, then it has big implications for things like muscle wastage, increased vulnerability to falls, all those sorts of things. So I think it really is vital that the homes are doing that sort of thing and trying to support that both mental and physical well-being under difficult circumstances in as creative a way as possible.
I think what you said earlier on, Stephen, was spot on. That I think we're very lucky with both the homes that we have and the relationships that we've built over the years, really, with those homes. And I would probably particularly commend my team manager, Jackie, who's done a fantastic job over the last, and her team have done a fantastic job engaging with the homes, encouraging, supporting, and trying to facilitate things as well.
I think some of the homes have been outstanding in how they've kept the morale of the residents up. I know it's what gets posted on Facebook that we can all see and what they've been doing. They've still been having the Easter bonnet parades, and I know one place had the Olympics through the summer, and obviously they must have had no COVID cases at the time because they were all a bit more closer together. But I think the carers, they're outstanding. I think that we really, really need to recognise our care assistants, our nurses, who day in, day out go out there and think of different ideas of how to entertain our vulnerable residents. And I hope Santa's very good to them this year when he comes round, and because they're definitely not on the naughty list this year. Would you like to come back there, Trevor?
Sorry, old hand there. Sorry, Sue. Beg your pardon.
But I hope please send our grateful thanks to all the care homes in your next update, and if we could all receive the weekly updates, if you could just put us in a group if you could send it all to us as well. I know I've been receiving them, and I know that the homes have appreciated the input that the council's given to the homes. And thank you, Jill, and your team. Great leadership gets great results. Thank you very much. And we just to note the report, and it's going to come back to us in 6 months unless anything changes. Yes, Stephen?
Just before I move on, could I ask Trevor a slightly different question? And with the very big focus that we have had on things such as the sort of hand hygiene and all the different things that have come with COVID, has there been reductions in other transmittable conditions within the homes as a result of that?
It's a difficult one to say that, but we have had, in one instance, we had an outbreak of D&V, diarrhea and vomiting, etc. So we have had singular instances of those other things, but it probably is the case, that there are other things that where we have tried to sort of keep the homes very well protected, that it has reduced some of those different things that could have happened. And I think possibly going forward, I don't think we'll go back to the new normal, not the old normal. So there'll be things that we will take forward, I think, across the care sector that will be different to what we've done in the past because of what we've learned over the last 9 months.
Thank you.
Right, thank you, Trevor, and please say thank you. Greatest thanks from our committee to all the care homes across the borough, including the learning difficulties and that. So the report is just to note, and it's coming back in 6 months unless other things arise. The next one is 7.2, hospital discharge. I believe that we're getting swung around in Trevor's office. Is it Susan, are you doing it, or is John doing it?
No, I'm doing it. Can you hear me? Yeah. Yeah, smashing. Thank you. So thank you, Chair, and good morning to everybody. So like you say, I'm bringing the report for the hospital discharge and intermediate care. There's no decision required. The report is for information only. So the purpose of the report is to provide the committee with an update in relation to hospital discharges and intermediate care. And these developments are aligned to the community integrated intermediate care model, which the strategic partnerships between Hartlepool Borough Council, North Tees and Hartlepool Foundation Trust and Tees Valley Clinical Commissioning Group. And this includes services provided and commissioned by the partners to develop older people in the transition from hospital into the community to live more independently in their preferred place of residence. So the background is the Better Care Fund, or the BCF plan. It sets out the ambitions to develop a more integrated service across health and social care to support people to live at home as independently and for as long as possible. Hartlepool Borough Council, in partnership with the CCG and the FT, we recognise the need to work together and improve the way in which short-term services and interventions are utilised to optimise independence and well-being, and build on a person's strengths and abilities, and in doing so ensure that intermediate care is delivered effectively. So in 2021, the BCF policy framework will be published in due course, but with systems needing to focus effort into dealing with the current COVID-19 pandemic, NHS England have yet to ask systems to produce BCF plans at this time. So although BCF plans from April 2020 haven't been formally approved for the duration of COVID-19 outbreaks, systems have been advised to assume that spending from ring-fenced BCF funds, particularly on existing schemes from 1920 and on activity to address demands in community health and social care, is approved, and that continuity of care, maintaining social care services and systems resilience should be prioritised. So there's an expectation that more NHS community intermediate health and social care packages will be delivered to support timely crisis care, avoidance of hospital attendance and or admission, as well as unnecessary admissions into 24-hour care placements. The ambition is to implement urgent responses, recovery support delivered by flexible teams working across primary care, community care, local hospitals to meet the local need. This includes collaborative working between GPs, allied health professionals, district nurses, mental health services, social workers, therapists and reablement teams. And it's envisaged that extra recovery, so reablement and rehabilitation support, will wrap around core services to support people with the highest needs. Throughout 1920, there have been a number of outcome-focused developments across the service, and these initiatives focused on admission avoidance, including residential rehab, residential step-down and step-up provision, intermediate care, mobile rehab and reablement support. And this work will be ongoing throughout the pandemic. It will take into account issues such as strengthening operations systems and focusing on workforce development and training. The intention is that once the current challenges have been addressed, the integrated intermediate care offer will be re-evaluated to determine future work patterns. So the current service model that we have in relation to the community integrated intermediate care has been developed to provide resilience, responsive and skilled service offer, mapping information and subsequent quantitative and qualitative data analysis has helped to define the potential benefits for this more collaborative, streamlined offer, and it's aimed at a number of areas. So there's improving the experience of the individual, reducing duplication, ensuring a single assessment where appropriate, delivered by the right person at the right time, reducing the time a person spends with the intermediate care services, maximising staff time to increase service capacity, delivering a more primary prevention, reducing the long-term complexity earlier, and preventing the loss of independence, developing a common set of outcomes which can be measured to demonstrate how well the offer is working, develop a home-first approach, and increase ability to respond to crisis and emergencies, and create a service that's more resilient now and for the future. So the hospital discharge service, the policy and operating model at the moment, in March 2020, a new hospital discharge service policy and operating model was introduced, which include a greater emphasis on the concept of discharge to assess. This is for all providers of commissioned acute community beds, community health services and social care staff in England. Discharge to assess, or D2A, as you'll hear it's referred to, is a process designed to rapidly discharge 95% of people from hospital once it's medically optimal and safe for the people to return home. So with this model, there's a limited assessment of rehabilitation potential within the acute hospital. Once somebody has returned home, detailed functional assessments take place and ongoing care and equipment are provided. It's anticipated that half of this group needs simple discharge and no more formal NHS social care support on returning home, and around 45% require a package of support, including rehab. A package of out-of-hospital assessment of rehabilitation and reablement as part of a model is provided free of charge for a period of up to 6 weeks. Although the discharge to assess model is not new, the parameters and the requirements outlined within the operating model have changed and do place more challenging expectations on the health and social care system. Many local services have been working to try and deliver a rapid hospital discharge approach for some time, but during the current pandemic, many acute hospitals introduced D2A on a temporary basis because of the urgent need to get people out of hospital as quickly as possible and reduce the spread of COVID-19 and free up capacity to treat very sick patients. The Hospital Discharge Service legislative framework has confirmed that the decision to keep D2A as a permanent model, driven by planning for potential further outbreaks and the implementation of an NHS long-term plan in developing capacity in out-of-hospital services. Successful implementation of the discharge to assess is dependent on sufficient staffing in acute, intermediate and longer-term community rehabilitation teams. Staff in acute and bedded rehabilitation teams need the capacity to provide rapid discharge decision-making and work flexibly where needed in the community to provide trusted assessments there. This can only be achieved through an increase in their numbers or via different ways of working. Without this adjustment, core rehabilitation time for inpatients who need it to expedite recovery and meet their clinical criteria for discharge will be reduced. Intermediate rehabilitation teams providing up to 6 weeks rehab packages identified throughout assessments at home will need to be fully staffed to meet this. Community rehabilitation provision for patients who require rehab beyond the first 6 weeks needs to be accessed quickly and at the intensity and frequency needed. Without this, there is risk patients will deteriorate and represent in primary and secondary care, and long-term social care needs will rise. While rehabilitation teams across the pathway will need to work closely together and also work flexibly, it's essential that the staffing required for the discharge to assess does not come at the expense of an already understaffed community rehab teams. From the 1st of September, the government announced that social care needs assessment and eligibility assessments for NHS and continuing healthcare, or CHC, would recommence, having been suspended since the 19th of March 2020. And there is now a requirement for a backlog of assessments to be completed by the 31st of March 2021, which is challenging in terms of staff capacity. Trevor briefly mentioned designated settings. So it was identified in the Adult Social Care and Winter Plan, which was published in September 2020, that alternative arrangements would need to be made by local authorities in partnership with CCGs regarding hospital discharges for care homes for people who have tested positive for COVID-19. And a letter to the local authorities on the 13th of October provided further details regarding this requirement and directed local authorities to identify designated settings. The designation scheme was intended for people who have tested positive for COVID-19 and who are to be admitted to 24-hour care. And this applies to care homes who provide accommodation for people who need personal or nursing care. This includes registered residential care and nursing homes for older people, people with dementia, people with learning disabilities, mental health and/or other disabilities, and older people. Anyone with a COVID-19 positive test result being discharged into or back into a registered care home setting must be discharged into an appropriate designated setting and cared for there for the remainder of their required isolation period. The letter emphasised that the need for designated settings was to be standalone units or settings with separate zoned accommodation and staffing, and designated settings were also needed to be separately inspected and assured by the Care Quality Commission to meet that requirement. So despite the best efforts of all partners working together and exploring the system solutions, we've not yet been able possible to identify a designated setting for Hartlepool, and there's no immediate prospect of this situation changing. Care home providers have been under intense pressure in recent months, and although they continue to do a fantastic job in supporting vulnerable residents and care with care and compassion, they are understandably concerned about maintaining services in the current climate. In this context, care homes are reluctant to accept admissions of people from hospital who have tested positive for COVID-19 for a multitude of reasons. High occupancy levels within Hartlepool mean that care homes don't have the space to accommodate a designated setting, and those that do have vacancies don't have a suitable physical environment to meet all of those requirements. Care home providers are also concerned regarding staffing, invalidation of insurance, reputational risk, and managing the duty of care to the existing residents and their employees. So there are ongoing discussions between Hartlepool Borough Council, our NHS colleagues, Foundation Trust and the CCG to explore alternative options. Another thing that's been happening is the enhanced health in care homes. So this is a model, moves away from the traditional reactive models of care delivery towards proactive care, and it's centred on the needs of individual residents, their families and care homes. And such care can only be achieved through a whole system collaborative approach. So the NHS long-term plan in 2019 contained a commitment as part of the Ageing Well programme to roll out the enhanced health in care homes across England by 2024, commencing in 2020. The enhanced health in care home model described in the framework that it will help to ensure that people living in care homes have access to enhanced primary care and to specialist services and maintain their independence as far as possible by reducing or delaying or preventing the need for additional health and social care services. Staff working in the care homes need to feel at the heart of an integrated team that spans primary, community, mental health and specialist care, as well as social care settings and the voluntary sector. Budgets and incentive are aligned so that all parts of the system work together to improve people's health and well-being. And the health and social care services are commissioned in a coordinated manner, and the role of the social care provider markets is properly understood by commissioners and providers across health and social care. The ethical care framework, whilst we've been working with the pandemic, we have the Ethical Care Framework, which aims to provide and support an ongoing response, planning and decision making to ensure that considerations given to a series of ethical values and principles when organising and delivering social care for adults. Recognising increasing pressures and demand, it may become necessary to make challenging decisions on how to redirect resources where they're most needed and to prioritise individual care needs. The framework serves as a guide for these types of decisions and reinforces that consideration of any potential harm that might be suffered and the needs of all individuals are always central to decision making. The principles of the framework are numbered for ease or reference, but they're not ranked in order or significance or exhaustive. There's no absolute answer to making the correct or most ethical decisions, but all of the principles are taken into account. So we have respect, reasonableness, minimising harm, inclusiveness, accountability, flexibility, proportionality, and community. If I move on to risk implications, as a direct consequence of COVID-19, recruitment and retention of the staff for Hartlepool Borough Council's direct care and support team to provide the face-to-face hands-on care has been a significant challenge that we have not previously encountered. In order to mitigate risks, officers' staff numbers have increased and workloads been prioritised, and we are remodelling where possible. The work of the health and social care workforce continues to be reshaped in an effort to contain the infection and protect the most vulnerable. The NHS has been mobilised to respond to the acute needs of people infected with the virus and at the same time as delivering a scaled-back non-COVID healthcare. Social care continues to operate within the ethical care framework of COVID-19 and action plan for adult social care policy paper underpinned by the Care Act. The government has implemented measures to help the care system manage pressures, and local authorities have been directed to do everything that they can to continue meeting existing duties prior to the Coronavirus Act provisions being enacted. In the event that we're unable to do so, Care Act easements allow the authority to streamline arrangements and prioritise care so the most urgent and acute needs are met. Officers continue to work in partnership with the FT and the CCG colleagues to look at developing alternative pathways to support people on discharge from hospital and manage increased pressure on the community providers. The fact that no designated settings have been identified for Hartlepool may create or have created a pressure within the health and social care system, but positive relationships with the providers mean that safe and timely hospital discharges are still being facilitated for people who have tested positive. That has some financial considerations. So the integrated intermediate care model is funded by the Better Care Fund pool budget, which is monitored by the Pool Budget Partnership Board and government by a pooled budget partnership arrangement, as outlined in 3.4 of the local system, operating on the assumption that spending is ring-fenced from the BCF funds, and particularly on existing schemes from the 2019-20, which have been approved for 2021. The legal considerations, we've already mentioned the Care Act easements, so there's guidance there for the local authorities setting out how adult social care can use the easements created under the Coronavirus Act to ensure that the best possible care for people in our society during this exceptional period. We haven't implemented those in Hartlepool to date. Any decision to operate Care Act easements will be taken locally by the officer fulfilling the statutory duty, the Director of Adult Social Care role, in conjunction with the recommendation of the Principal Social Worker. So the Director of Adult Social Care and the Principal Social Worker must ensure that the lead member has been involved and briefed as part of the decision-making process, and any decision will be fully informed by discussion with the CCG. This report has no impact on child and family poverty considerations. The Ethical Care Framework provides guidance to local authorities in relation to the equality and diversity considerations. The Hospital Discharge Service for staffing, the policy and operating model specifies that social care support for hospital discharge should be provided 7 days a week. So working in partnership with health colleagues, this enables this to be managed currently by operating. We've got an extended working day from 8 o'clock in the morning till 1800 hours or 6 o'clock in the evening. An additional staffing is being funded from the COVID grant to meet these requirements. While there are no further staffing considerations specifically associated with this report, it should be noted that any national emergency on the scale has not been encountered in the UK within most people's lifetime. The impact on staff has been significant, with many feeling fearful about the ongoing risks and the uncertainty. Supporting staff to maintain their physical and mental well-being during the pandemic is paramount to enhance personal resilience so that individuals and groups have better capacity to undertake their roles. And employees' wellbeing services have adopted Every Mind Matters, which is a new way to help people take simple steps to look after their mental health and improve their mental wellbeing and support others. There are no asset management associations specifically associated with this report. Hartlepool Borough Councils working within the hospital discharge team and intermediate care services continue to be based at the University Hospital of Hartlepool, where we continue to support the integrated service across health and social care, and appropriate health and safety measures are in place to manage the working environment. Individual discussions have taken place with staff, including those who are clinically extremely vulnerable, to address any concerns regarding working from home or in a COVID secure office environment. So really the recommendation is that members of the Adult Community-Based Services Committee note the content of the report, the current challenges that are being faced, but the benefits that the model will generate for the people of Hartlepool.
Thank you, Susan. That was quite detailed, and I think it just highlights that people are still scared of this pandemic. It's not a 2-week bug of sickness and diarrhea where you think you're going to get over it and done with it. It's how many months now? 9 months into it, and people are scared, and these carers and nurses and district nurses and everybody else, they're putting their lives at risk every single day. I'm just so proud to be able to say the words to say thank you. And I know some nurses are scared. I know you can't car share no more, but when people didn't realise people were car sharing, they were spreading it from one ward to another. They refused to give the colleague a lift home because they didn't know. And it's just that society's just gone mad, and I honestly take my hat off to all of these carers who are doing this and looking after our most vulnerable people. And thank you. Does anybody want to come in and say anything, or are we just going to note the report? Susan, do you want to come back there, or are you?
Yeah, can I just say, obviously, as an update, we've mentioned the lateral flow testing in the care homes. It's now in relation to our home care, our domiciliary care providers and any staff that are supporting in that area, we now into our 3rd week of doing the lateral flow testing as well. The responses aren't as quick as we were speaking about before in the care homes, but we are getting an answer to all of our tests within 24 hours. So that's rolled out to all of our staff that are supporting, doing any hands-on, any face-to-face contact. The last 3 weeks, Hartlepool have been supporting the staff to do that.
Thank you for that. That's a little bit more reassurance. Stephen, do you want to come in there as well?
Yeah, thank you, Chair. I think that the model that you've outlined, Susan, the discharge to assess, it's been developing for quite some time now. And I think it's probably fair to say that COVID has accelerated rather than introduced it per se. And I think that from my sort of Health Watch perspective, I'm yet to come across someone who has said that they would like to have been in hospital longer. And from the patient perspective, getting out of hospital is always a really big thing. But I think that's got to be balanced with a speedy discharge has got to be balanced with the right support packages, the right communication having happened prior to the discharge between community teams, GPs, and a whole plethora of people who are going to be involved within the local authority, lots and lots of different people to ensure that that discharge is safe and that the recovery and rehabilitation process for the patient, for the individual, is going to be in place and is going to be up and running as soon as that discharge happens. And I know in 5.5 on the report, I think you quite rightly draw attention to the need for appropriately resourced teams to ensure that this happens properly. And I know that from information that's come through Healthwatch England, there have been examples up and down the country where this hasn't necessarily always happened as it should during COVID, and probably before COVID with discharge to assess. And I think that one of the things that we need to feel confident about as members is that those resources are in place. And I think there's only so far that we can go as a local authority to answer those questions. And I think at a future meeting, Chair, it would be really interesting to hear from our health colleagues about the other side of the equation, about the community health provision side, about the process that happens while the person is still in hospital. I think to give us as members those assurances that I think are needed in order for us to have the confidence that people who are being discharged are going to have that full and proper package of care immediately and properly in place. And I think, as I said at the start, no one wants to be in hospital a second longer than they need to be, but people need to go into the right sort of care package immediately at discharge. And any delay, even if it's just a day or so, can have quite big ramifications for the longer term rehabilitation of the individual.
I totally agree there, Steve. Who's got mic on? Sorry, it's just background. It was just through me. If we could invite to one of our meetings, I think the next one's in January, but might be a little bit too soon to organise for that one. But maybe the one after that, if we could ask our health colleagues to come along, hopefully. And with Teams, it's a little bit more safe and secure for everybody. No mixing, unless we've all had injections. But unfortunately, I'm maybe a little bit too young for my injection yet. I have to wait. Maybe have to wait for the next batch. Would you like to come back there, Susan? Historical hand that you've got up there. Yeah. Are you on mute still?
Sorry, my fault. I had to move. John wants to speak.
Stephen's completely right. Is we need to take a bit of time to reflect what's happened over the last 9 months, and also what's happening going to happen over Christmas. And then is we do need to have a conversation with our colleagues from the CCG, because they're commissioned people like the Foundation Trust to deliver healthcare, and it would be really useful for members and help their understanding of how the working environment, health and adult social care has changed and has changed and constantly with the pressures that are on all the systems and processes. So I think it's a really good idea.
Can I also just address the comment that you made there, Stephen, about those decisions? And obviously, speedy discharge also needs to be a safe discharge. And I think that's where the ethical care framework comes in. It supports the staff to make those decisions with those principles taken into account, the respect, the reasonableness, everything that's listed in the report.
I don't know if you're all in agreement. Our next meeting is in March, so if we could add additional meeting, if nobody is objecting, so we can ask the CCG if they would like to come along, and hopefully by that time more people have had injections. Hopefully the world is starting to come back to some kind of normality, and to see how they're coping with discharges and everything, and give their perspective on it all. So if you all agree with that, if we could have one in March. So, sorry, February, not March. Thank you very much, Susan, for the report. It was very, very, very useful. Just highlighting more of what this horrible pandemic has caused us all. And thank you to your team and for the excellent work and support that you're giving to all of these organisations and residents and everything. And thank you. Please send my best wishes to all of its staff. Thank you. If we go back on now, quickly, swiftly move on to 7.3, and I think it's our lovely Gemma. You're on mute, Gemma. We can't hear you. No. Is your headset plugged in? Or is it on your thing, that bit there? If you check that one.
Am I on?
Now you are.
Oof. And I did such a
technology, isn't it?
wonderful. I know I did such a wonderful. Good morning. I think we're still in the morning. So I'm bringing a report back on Support Hub. I know that I did quite a detailed report on this in the last committee, and I said I'd bring back on some of the future planning. And since the last committee, we went into a lovely lockdown again. So a little bit of update on that. So I'll whiz through it and then take any questions. So in terms of the national lockdown, just to kind of note, there was a change from those that are shielding to those that are clinically extremely vulnerable. So a slight change of terms. So what we did is we worked with the previous list that we had. There was 4,883 people identified in Hartlepool that were clinically extremely vulnerable that we supported through a second lockdown. Of that number, because of all of the wonderful work that the teams had done around person-centred planning and how we supported people as we paused from shielding, there was only 200 people that came forward and registered with the national system. And about 70 of those as needing a high level of support. So we contacted everybody, but actually the infrastructure that was put in place previously was really positive, and it meant that the demand was quite low and has been low over the 4 periods of lockdown. In 4.2, it identifies that the second lockdown wasn't about giving food to everyone. Previously, it was about ensuring that people had what they needed. But this time around, it was much more around access. And what we were able to do is put in a really sustainable opportunity for people to access food, and whether that's through priority shopping slots, etc. So we were only giving out about 3 to 5 food parcels per week, and that was usually an emergency measure. And then we got people some longer term, more sustainable options in place. 4.3 identifies the levels of calls that were coming in. It was only really 20 to 30 per day. And actually, we were much more proactive in making calls. So really, the calls coming in were about a quarter of the workload. For every 1 call that came in, we were making about 3 calls out and working much more proactively because we knew the individuals, we knew what they needed, and we were following up with them very actively. 4.4 identifies that prescriptions, there was a change this time that pharmacies received funding directly from government to provide prescriptions to those that are clinically extremely vulnerable. And we supported those who were continuing to be vulnerable and still needed that access, but that demand was much lower again this time round. 4.6 identifies some of the work that we've done around our digital offer, and there's a little bit more context to that later, but we've got 2 digital officers in place now that we've appointed on some fixed term funding, and that's really working with people to get access to connectivity and technology. 4.7, we continue to work with Mecca Bingo, who we worked with in the first lockdown, and because they weren't able to open to the public, they've continued to provide hot meals, and we've given about 50 people per day a hot meal, and they were typically people that would have previously accessed day services, and that's been a really good partnership. So in terms of moving forward, 5.1 identifies that obviously the Support Hub is a permanent part of our services now, and there's a wealth of opportunities for us to continue to evolve that. We will relaunch the Hub in the new year, and that will be able to kind of really complement the community-led support work, of which there's a report on that later. 5.3 identifies some of the review with our library service. We know during the period of lockdown that the trends and demands on our library service have been much different, and we've been doing some low-level consultation with our current users. Our BorrowBox library offer has increased significantly, which has been extremely positive. So we're looking at how we review and manage our stock differently, and also review and manage our spaces. And we know that there's quite a big demand on our local history work that we do. So we're going to evolve the Headland branch library into a family and local history centre. And that's a really exciting piece of work. We're working with our colleagues in Heritage as well. 5.4 gives more context to the digital offer that we're putting in place. One of the big pieces of work that we're doing is rolling out a community broadband programme with our colleagues in Hartley Power, and this will mean that it's a plug-in solution with no engineers needed, and people can get access to internet connection, and this is a real low cost as well, so that's a really positive piece of work. We know that some of our administrative functions have changed because we have moved to more digital and virtual solutions, so that's under review. And also we're looking at how we further enhance our offer, which is detailed in 5.6, and we can really build on a lot of the learning over the past 9 months, but also some of the developments that were taking place beforehand, as well as also working on the alternative model for day services. Moving on to 5.7, it articulates the procurement exercise that we've now completed, and the bread and butter thing have been identified as a provider for us to be able to put in place a sustainable solution for access to food, and we'll be launching this early in the new year as well. There's obviously ongoing risks associated to COVID-19, but we're managing this through our mitigation plans and also business continuity. Moving into financial considerations, the ongoing work that we're doing is being resourced through existing infrastructure, as detailed in 7.1, but also there's some context there about some of the settlement that we achieved from government as part of the second lockdown. Some of this will obviously be there to provide immediate response, but we're also investing that money to ensure that there's some long-term, more sustainable solutions linked to the digital offer, and linked to some of that person-centred planning, ensuring we've got the right infrastructures in place. We're also doing a really significant level of support over Christmas. We've had lots of provisions starting to go out to those most vulnerable in need to ensure that Christmas time is going to be as positive and enjoyable, and they have all of the what they need throughout that time. So the team are doing a great piece of work on that at the moment. In terms of additional costs for the support hub and the digital offer, this will be covered within our existing framework of budgets. Legal considerations, there isn't anything imminent, except there is a procurement exemption linked to the progression of the community broadband programme. Consultation, we've been doing a huge amount of consultation throughout this period, especially with those who are clinically extremely vulnerable or previously were shielding, and their families, as well as some of our wider partners and other service users. Obviously, from child and family poverty, the work that we're doing has a significant impact, and certainly we want to try and mitigate some of the risks of that within the community. Equality and diversity, we continue to ensure that what we provide is extremely accessible, and we're considering all of those aspects within our planning and continued service model design for the future. There are some staffing considerations as part of the work that we're going to be doing. Obviously, we know there's been a huge level of redeployment and repurposing of our staff and services over the lockdown period to respond to the pandemic that presented itself. So we're trying to ensure that we use some of that, and there is a full restructure within the Community Hubs and Wellbeing service to ensure that people are in the right roles, and we're now providing the services that the community need. There will be potentially some risk to staff during this time, and we'll ensure that anything that we do is in line with the HR policy and procedure, and also working with our partners within the unions. And for anybody that's at risk, we will do our best to ensure they're redeployed. We hope this to be as minimal as possible. Asset management considerations. We are repurposing Community Hub Central, and there are some capital works being developed in there at the moment, and that will ensure that the building is much more fit for purpose, and when we can reopen to the public, we've got a much greater offer to provide what we know is needed. So just to finish on the recommendation, which is that members of the committee know our current position and the positive work that continues, and also our plans for future development as outlined in this report. Thank you, Chair. Happy to take any questions.
Thank you, Gemma. I would like to say thank you to your staff as well, especially in the support hubs who've been redeployed into picking the phones up and to speaking people, because it's not easy for anybody. Like I love talking. I could talk for England on the phone, but many people not like me find the phone as, oh my God, who do I have to phone? Who's going to be at the other end? What's going to happen? But they've taken it in their stride. And I know that they've sent birthday cards out to residents who've never had, who wouldn't get one because of they were shielding. And just how the Christmas lunches that they've organised and the little small gifts, just because they can't go out and do these things for themselves. So somebody's had a brainwave and thought, oh my God, they're not going to have a Christmas tree, they're not going to have a bauble, they're not going to have a Christmas cracker. So your team's solved that problem. They've gone out and done it. And thank you. And I think we should write a letter to Mecca to thank you for all the lunches that they've done over the first lockdown and obviously the second lockdown. Hopefully, please, if we all be sensible, we won't have a third lockdown. And I'm crossing everything that doesn't happen. But to thank Mecca Bingo for the support that they've given to our day services, supplying those hot foods where some people might not have had a hot food. Does anybody like to add to what I've said, or Stephen?
Thank you, Chair, and I would echo those comments that you made. Just a couple of things to pick up, Gemma. And on 5.3, talking about the library offer being refined and refreshed. And I think that libraries are quite a emotive subject. And I certainly know that there is a lot of strength of feeling out there in the community about the importance of library provision. And I think that what would be really useful for members is if we could get a fuller update on just what is being put forward there and the sort of direction that libraries are envisaged as heading down in the future. As I know a lot of emphasis around some of the digital content, but I think for a lot of people there is still a requirement to maintain the actual physical book content and the actual sort of hard book offer for people, as well as that digital offer that clearly has got a place going forward. I think also I would like to hear a little bit more about the community kitchens and chatty cafe offer. One of the areas around the chatty cafes that I've had a little bit of involvement in the past is around their role in supporting people who are living with dementia and offering a space for people to use who are living with dementia. And I was just wondering if that sort of thing's being incorporated into the chatty cafe provision, as I think thinking about those times when we're getting back to a little bit more sort of normal and are able to go out and use cafes in that sort of way. I think having that sort of provision in Hartlepool would be a really excellent thing for us going forward. And I think the final thing is just thinking back to the report that we had at the last meeting around community-led support. And again, I think the report is very heavy on that sort of like digital input going forward, and thinking about some of the sort of like more traditional ways of supporting people. I think community-led support is really going to have a very important part to play in some of those more traditional ways of supporting and enabling people who are isolated within our communities. I think clearly digital, internet, social media sorts of inputs are very important, work very well for certain people, but there are people out there in our communities. And I think, again, COVID has really, really highlighted this around the social exclusion that can come from not having platforms other than social media approaches to things. So I think that's got to be an integral part going forward. And I think our community-led support work that's being developed by Lee, I think it's going to have a really fundamental part to play in complementing and working with some of those digital ways of working that you've been talking about.
Do you want to come back, Gemma?
Yes, please. Thank you, Chair. Yeah, thank you, Councillor Thomas. Absolutely valid points. And in terms of the library offer, if I can pick that up first, we are working through a more robust strategy and plan around the library offer, reflecting a lot of our learning and also working with some of the information that's coming through nationally as well and interpreting that. I think it's just to reiterate, although we have moved to very much a digital and a virtual offer, we are still running a very comprehensive click and collect programme, not just from our main buildings, but our mobile library going out into communities for people to be able to pick up from. We continue to deliver our home library to those most vulnerable, so actually getting books regularly to their home. So we are working through that, and all of those will absolutely be sustained as we need them to. And I think in terms of the book offer, that will absolutely be retained. We don't anticipate that we'll move to a full digital offer, but it'll be very much a blended approach and trying to work with the demographics that we know require different approaches to the library offer. There will be some rationalisation of our stock, but this is very much informed by intelligence. An example is we've done some testing on when some of the books were last loaned out, and there's still some stock amongst our library offer that got last loaned out in 1954. So, you know, there's some real justification behind moving some of our books on, because you know, the reality is that we've had them for a very long time, and obviously there's room now for us to bring in better
that was
stock.
probably Carl who got it out.
Well, we'll make sure, Carl, when it's on the online sale platform, we'll let you know. But yeah, you know, we are making sure that anything we do is very much informed by intelligence, and we won't be reducing an offer that we know the public are very much wanting to continue to access. But I will bring that back to committee at a later date. Sorry, just to pick up on the Community Kitchen Chatty Cafe, this was some work we started piloting in Community Hub South before we went into lockdown, and absolutely the things that you've mentioned are an inclusive part of that. What we need to look at is our recovery planning and how we move into building-based opportunities for people coming out of you know, the offer that we've currently got. So that is very much up for discussion, and Lee is on the next item for community-led support and may be able to articulate that in a bit more context. And likewise with your final point around the digital opportunities and community-led support, Lee is presenting the next item and we'll be able to pick that up there.
Thank you, Gemma. Sorry, fancy calling Carl that he hasn't got a book out for how many years. I know my residents in Seaton are really keep on asking when's it going to be open back, because a lot of them used to go there to read the daily papers, which we haven't had since March, since pre-pandemic, because obviously we couldn't share newspapers. That was another thing that hit a lot of people hard, probably hit the pockets a little bit harder too, because they would have to go out and buy them themselves if they wanted to. But thank you very much, Gemma, and please thank your team. We will note the report, and if there's anything significant to bring back earlier, bring it back to committee as soon as you can, if anything exciting is happening. If we go now on to 7.4, I'm not sure if it's Jill or Lee who's going to present this. That's Lee. Good, you're on mute, Lee.
Thanks, Chair. I think it's a bit of a double act between me and Lee, so I'll just kick off, and then Lee will come in and tell you about some of the exciting things that have been going on. So we've brought updates to committee previously about community-led support. It's a piece of work we've been doing with some support from the National Development Team for Inclusion. And it's about how we change our offer really to make sure that we're promoting community solutions, that we're making sure that people are able to access our services more easily through the community. There's some detail in section 3 about the background, which I won't go through because members will be familiar with. But really, we just wanted to bring this report to give a bit of a progress update and talk about next steps. So I will hand over to Lee to pick up that bit.
Thank you. Morning, thank you. So where we've got to so far, so by summer 2019, we trained 339 people. We've done a lot of work reviewing and changing our paperwork to support the new system. And we launched our innovation site in November 2019. So between November and March 2020, 161 people were supported in the hub, coming thereafter contacting the iSpa. So it was a really building up nicely. We held 2 market stall events with voluntary and community sector members, and Hartlepool carers joined our innovation site on a permanent basis. So it was providing a really seamless link for carers. So the demand was growing, and we extended our opening times in our central site and launched a new site in South Hub. We were getting really positive feedback from people who were coming along and really good feedback from staff who were involved. We literally had just started offering some mental wellbeing sessions in the hub with Alice Hospice wellbeing services, which are being taken up really well. And then we had lockdown, so it all stopped. So we moved into the support hub, but was working under the same principles of community-led support. So all of our conversations were really strength-based, and they really focused on good, positive conversations. We collaborated really well with the voluntary and community sectors to support people to find the best possible outcomes. And I think that's been a really positive development for us, and we've continued to improve the relationships. And they've now set up a CLS partnership group with a small number of VCS organisations that include Hartlepool Carers, the Hospital of God, Hartley Power, Stephen in his HBC mental health champion role, Incontrollable, and Cleveland Fire Brigade, who commissioned to provide our befriending network. And that's been a really positive partnership that we've established. So we've met fairly frequent. Sorry, lost the ability to speak now. We meet fairly frequently, and part of those discussions, we started looking at some of the people who were coming through the support hub during the pandemic, just to try and get an understanding of how we might work together going forward. And it's been really positive. I think there's been some really good outcomes for people because of that partnership coming together. So we're now looking at how we can share information using our Firm Steps platform. We've developed jointly a new support tool that we're all using. So we're actually using the same paperwork to support people. And we're sharing information about individuals. So we're actually having discussions about people to see who's the best person to lead and to take that person forward with them. So it's been a really positive outcome, I think. And we're really hoping as we move out of lockdown and maybe are able to get people back in, it will be a really positive way of working with people going forward. So as part of all this work as well, we've also been involved with a thing called a community lens audit, which has come through the NDTI partnership. And it's a tool that's helping us understand how staff approach the development of community solutions, and which will then help us identify our priorities. So we sent the questionnaire went out in about September, and 222 members of staff completed the audit tool. And there were some really good positive findings initially, with over 80% rating the VCS services in the town as either good or very good, and 55% reporting that they'd replaced a paid service with a community service for someone, which feels really positive considering we've been in lockdown since March. And 77% confirmed that they would routinely consider community solutions to address isolation and loneliness. So I think from a cultural point of view in staff, we're beginning to see a shift to community-led provision. So our next thing really is to continue to analyse that data and understand where we are with staff. Jill?
Thanks, Lee. It's a really helpful summary. And as people have said, it links very much to the previous item around the support hub and the fact that we already had some really good developments in place. There's actually a lot more learning to come from the COVID response, and it's really positive that we're able to take that forward and maintain the support hub offer. So there's some information in section 7 about next steps. As Lee said, we're building on what we've already done in terms of using community-led support as our front door. The partnership group's a really positive development, and we'll continue to build on that. And we're doing some further analysis of the findings from the Community Lens audit so that we can look at what our priorities are going forward. There's a CLS Champions network across the department, so we're going to use that to identify people who can promote the community-led support approach and spread that learning across the department, and just make sure that people are still using what we've previously had in place, so things like Hartlepool Now and the community connectors, to make sure that we're maximising the use of those resources. What we've also recognised is that there's a need for us to look at alternative services. So members will recall we previously had a building-based day service at Hartfields for older people. Obviously, that's something that we can't provide at the present time, and that contract's come to an end. So we're looking at how we can develop more alternatives in the community to support people to do things differently. And a really successful model that's used in other areas is around micro providers or micro enterprises, very small organisations that employ sort of a handful of staff and can be much more flexible and meet people's needs differently in the community. So we've developed a proposal for how we can look at creating more of a vibrant, flexible market locally. And we're hoping to be able to pilot something over the next 12 months. We've been doing some positive work with Hartley Power around that. And it's something that we hope that we'll be able to develop over the next 6 to 12 months. In terms of financial considerations, the support from NDTI was funded from the Adult Social Care Transformation Reserve, and we continue to access support through NDTI. It's a really helpful way of learning from other areas that have implemented similar approaches and sharing good practice. So that's really helpful for us to have that network to call on. And the recommendation is that the committee note the report, note what's been achieved to date, and our plans for the further development of community-led support. Thank you, Chair.
Thank you, Jill and Lee. Stephen, would you like to come in there?
Yes, thank you, Chair. And Lee outed me there. I should have made a declaration under the declarations of interest of having an interest as part of the working group that's been involved in the development of some of the things that Lee's been talking about. But I think for me, it's very much what it says on the tin, really, is very much community-led. And I think that very often we'll hear lots of talk about having people-centred care, personal decision-making and personal choice. And community-led support is very much about enabling that. And thinking through some of the development work that has happened, thinking through some of the case studies that we've done, it really does illustrate just how important having the person, the individual, at the centre of designing what's going to be right for them is. And I think one of the things that we are very lucky with in Hartlepool is the excellent community and voluntary sector that we have, and the ways in which they can get involved with and support people and help people design what's going to be right for them is a real asset for us going forward with community-led support. And I think the thing that I would say about the process, it has been an absolute partnership. And I think given the nature of that partnership, I think that the initiative can only go from strength to strength with the buy-in from all of the different partners who are currently involved in it. And I think the last thing to say really is very much about having the person at the centre and getting the right support at the right time in the right place for them. And it's very simple, basic stuff when you think about it, but very often those simple, basic things can be quite difficult to achieve and can get a little bit lost along the way with a lot of the complexities that are out there. But I think it's an excellent initiative, And I think, as I said earlier, really complements some of the digital things that are happening, and I think gives our overall package going forward that balance that's needed to meet the needs of the wider community out there. So thanks to Lee and the team for the work that they're doing around that.
Thank you, Stephen. Jill, do you want to respond to that?
Just wanted to thank Stephen really for the support for the approach. It's something that, as you say, it's relatively simple when you read what we're talking about. It is about supporting people to access what's already available in the community. It's about looking at very tailored solutions for people. And actually, we've already had, despite the challenges of lockdown, we've already had some examples of people who've been supported in this way and had really good outcomes. So hopefully, as we go forward, there'll be more of those sort of good news stories and positive outcomes that we can share just to demonstrate the benefits that this approach is having. But just to agree with Stephen, I feel like we've got a very strong foundation, some really good working relationships. And hopefully we will see this go from strength to strength next year when hopefully the circumstances might be a little bit less challenging. Thank you.
I think that's it. What you're doing, like all these, this is just one of many things that we've grown with, and we can thank the pandemic for for how we making things to fit the individual needs instead of going to a day centre and between 9 and whatever. This is just tailored for them, and it might be 1 till 4. There might not be a morning. If somebody got me out of bed when I was 18-year-old to go and sit in a day centre, I don't think I'd be very happy. I just want to lay in my bed a little bit longer. Never done it all my life, so I'm planning on starting when I retire, and I'll probably be about 80 when I have to retire. But it's brilliant that there's so many people coming together and singing off the same hymn sheet as well. It's just fantastic, really. And thank you, Lee, to all of your team and everybody for doing such a grand job and getting all of the other voluntary sectors and Stephen all on board and hitting the right buttons. So the report is just to note, and you're going to bring back more good news stories in the new year, which we would greatly receive because we all like good news story. It's not all doom and gloom. But thank you, Lee, for the report, and please thank all your support staff behind the scenes and thank them, and have a nice Christmas. Our next one is Gemma, I think, active hospitals. We're all going to be doing the gym.
Yes, yeah. I know that in the last committee this was mentioned and some more information was asked to come back. So it's just to kind of share a little bit more detail on the Active Hospitals programme. This came from a kind of pilot programme with Public Health England and Sport England to look at the feasibility of engaging physical activity in more of the secondary care settings. There was a pilot programme delivered at Oxford University NHS Foundation Trust, and in the background it gives some detail regarding what that process looked like. It was very much around training staff and being able to put the right infrastructure in place to increase physical activity. As a result of this, there was an open application for other sites to apply as part of the phase 2, and North Tees and Hartlepool Foundation Trust, along with Sheffield and Northumbria, were successful in being identified as the 3 new sites for active hospitals. Nottingham Foundation Trust have also since been added to that list. So 3.7 identifies, I suppose, the context as to why this is proposed, and the importance of healthcare in supporting people to be more physically active. And in 3.8, it identifies the priorities for the programme moving forward. North Tees and NHS Foundation Trust worked actively with us as local authorities and also with Stockton Borough Council in the development of the submission. And since the implementation, we're heavily involved in the working groups around that and the strategic decision making. The active hospital focus for the North Tees and Hartlepool trust is based on inpatients and outpatients. And in 4.3, there is an illustration there regarding how some of that's going to be done. So from an inpatient offer, we're looking at acute cardiac unit and also elderly care frailty. And some of the work that will be done around that is around managing expectations with the patients once they come into hospital, and again, based on strength-based conversations around what they can do. So I can boards will be part of people's care, being able to identify what people can do to ensure that's sustained, and also what kind of activity they're able to engage in. There will be a lot of involvement from volunteers, and there'll also be a lot of championing throughout this. Further down, it identifies some of the success measures, and that is really important, especially when we're looking at length of stay, pressure sores, the risk of falls, and then some of that wider case studying. The outpatient offer is for children who are overweight and obese. As we know, locally, we are one of the highest nationally in terms of our childhood obesity figures, and we're also looking at integrated MSK, musculoskeletal conditions. So that'll include orthopaedic and rheumatology, persistent pain pathways, and there's an illustration there around how that some of that is proposed to work, but the detail of that is being worked through. And then again, further, there's some success measures. Again, that's being worked through at the moment. There's quite clear links to the voluntary and community sector, and one of the priorities for this is how we work through clinical but also community-based pathways. And there has been a kind of lead champion to lead this programme. And at the minute, we're currently doing a lot of baseline work. So there's a lot of baseline information being collected to ensure that we know what we're doing will be well measured and evaluated for future planning and delivery. Obviously, this is a significant development for physical activity promotion holistically. And from our perspective, it's really important that we try and use all mechanisms for people to become more physically active. We have 1 in 3 people classed as physically inactive, so they actually do less than 30 minutes per week at a moderate level. And the associated health risks to that are really quite significant. There's very little to consider at this stage when we're looking through the further sections, because we are going through a lot of the planning and baselining, but we will be dedicating some staff resource to this to be able to ensure that we can see this through. Also, from an asset management perspective, we are working with the NHS Foundation Trust around how some of this could be delivered in the community as well, so that when people are being physically active, especially within an outpatient setting, they could start that process within some of our assets once we're able to, and then that helps sustain their physical activity journeys as they move into a community-based pathway. This will obviously contribute towards the initiation of our physical activity strategy that we're planning to work through, and obviously the engagement of healthcare will be a key part of that. So the recommendation is just for the report to be noted, and any future implications will be brought back to committee. Happy to take any questions.
Thank you, Gemma. It's quite exciting because we've talked about the pandemic a lot today, but hopefully we might be able to do things outdoors as well. And like in groups, I mean, like outdoors, like probably like I always think Seaton, because obviously I live there and that's who I represent, the Seaton ward, is being outside the library and having some kind of wheelchair aerobics, when we might not be able to go in an indoor space, but an outdoor space we might be able to do like some. And I've always wanted a volleyball net on Seaton Beach. I might get my wish one day, because that volleyball net could also turn into a badminton net, that would encourage people. And if I ever do get my dream, I might get me outside fitness suite on Seaton Beach as well. Well, on the prom. All these milestones I want, but this big thing called C19 is just absolutely booted us left, right and centre. But lots and lots of positivity, and hopefully we won't be in the red for our obesity anymore, with all of especially with the team's work behind it and the future insights of things. Hopefully we'll be in a good place very, very shortly. If I take Stephen's question.
Thank you, Chair. Yes, I think it's an excellent initiative, and are the social prescribers and our GPs fully engaged with the initiative? And you've talked in the proposals about the Foundation Trust being actively involved with the local authorities. Is there any financial commitment either from the CCG or from the Foundation Trust to actually support the initiative in a more tangible financial way, as otherwise the full costs could fall upon the local authority when clearly there are some very strong health outcomes which could come from this and from this approach. And certainly we hear a lot of rhetoric from the Hospital Trust and the CCG about the importance of this sort of initiative.
If I can just come back in there, Chair. I mean, in terms of the engagement of the kind of wider social prescribers and the GPs, that they're aware of this, but it's just important to mention this is very early stages. We are kind of doing that baseline work and creating those networks and infrastructures around that. So that they're absolutely informed, and we know again from a community-based approach, we're working extremely closely with the GP Federation and the social prescribers through HASH at the moment, and they're part of our Healthy Communities work that we're doing. So again, it's some of our responsibility to ensure we can link this up from a community-based planning perspective, and also working with the trust to understand what networks that they're leading into. In terms of wider financial support, that's not there as far as I'm aware at the moment, but I think it's important to note that this is a pilot project. The intent and purpose of this is for us to be able to create a level of evidence to justify why this is critical and important, and I hope that then from a future sustainability perspective, that evidence is used to be able to try and have those discussions and create those opportunities, because we know from the work that we're doing in the community from a kind of wider physical activity, leisure and sport perspective, then from the active hospitals side of things, and then some of the aspirations, as you say, around the outcomes across wider health colleagues. What we're trying to do through our Healthy Communities work is try and join all of those up where the shared outcomes. How do we ensure that the resource has been deployed in the appropriate areas? But it is about getting some of that evidence base and being able to then accompany those conversations. So there's some really positive work happening. We're really early days with it, but I am really confident as we move forward, we start to maybe challenge some of our traditional ways of working and thinking about how we do that differently.
Can I just come back in? I absolutely agree with everything that you've said there, Gemma, and I think one of the challenges has got to be around some of those funding arrangements as well. And I think with the body of evidence that you will undoubtedly collect, I think some very effective cases can be put forward, and I would hope that it would be backed up by some joint financial packages to support that work going forward, as I'm sure that this approach will have some excellent outcomes, both with regard to social care, but for also other health costs as well.
Totally agree, because everybody would benefit, especially the NHS, if we all started being a bit more active. Do you want to add something there, Carl?
Yes, it is an excellent initiative, and it needs to be developed, and we're talking about long term. And I think Steve's absolutely correct about getting other people to help finance that as well, because everybody will benefit from it eventually, and the town as a whole will benefit from it. Is it? I wonder if Sport England would be interested in stuff and taking up this initiative as well. What do you feel about that, Gemma?
Just to mention, Carl, that it's Sport England and Public Health England nationally that are funding this programme.
Right. Okay,
so there is funding being allocated to this particular pilot, not for the wider, and that is led by Sport England and Public Health England, which is a really positive step actually, because those organisations come together on a national level to be able to identify the importance of this is really, really positive. So absolutely, Cal, and some of the work that we're doing locally as well. So some of the funding that we're looking to secure for the new leisure centre, for example, where we're able to articulate that we're working in this way with colleagues, and that represents some of their wider aspirations across programming, it's really positive. And there's colleagues now sitting on the governance arrangements for the new leisure centre from the NHS to be able to work on that real robust collaboration of how we're future-proofing some of these things. So yeah, absolutely agree. Sport England at all levels are very engaged in this, and I think that bodes really well for us for the future as well.
When would it be possible to have a further report on this? And I'm particularly interested in the participants in this initiative as well.
I'll be able to come back to you on that one. We have got a meeting in the new year to be able to look at where we are with some of the baselining. What I will try and do is bring something back in this municipal year, if that's helpful. So if I can say that by March I will bring something back, then that if I can do it before then, because we've got the right information, I will do. But I'll bring something back before March.
Thank you, Gemma. That's really helpful. And I think I just think we're pioneers. We're such a small town, but we pioneer so many good causes. And this is another one where we're just going to excel. And we might be small, but we're big and we care. But thank you. So obviously you said you're going to bring one back in March, which will be absolutely brilliant, especially if we get some participants' feedback on it as well. And last but not least, Mr. Neil Harrison, who sat there patiently listening to us all blabber on. I'm sorry, Neil, that I do tend to blabber.
That's quite all right, Chair.
I've really been looking forward to this report because a lot of us have been worried about this, and hopefully you're going to put our minds to rest now. Thank you.
Well, a big ask, but good afternoon, everyone, and thank you, Chair. This is This is a report for information in regards to the Brain in Hand pilot. It is to provide members with committee members with information on with regards to a 12-month pilot. Background to this is that good mental health is an asset and is also linked to good physical health, both of which support positive social and economic outcomes for individuals and society. As we know, mental health disorders account for almost a quarter of the total burden of ill health in the UK. Poor mental health is strongly associated with social and economic circumstances, including living in poverty, low quality work, unemployment and housing. And there is also a strong evidence base for increased prevalence of mental health disorders following disasters, including evidence such as the COVID pandemic that we're living in at this moment in time. So the proposal essentially is that this Brain in Hand is a professional digital support system which will help people to make decisions, manage anxiety and deal with unexpected situations. It's for anyone whose day can be knocked off track by anxiety, unexpected events, or the need to make decisions under pressure. It's not condition specific. It is better thought of as an aid for people who find it hard to remember things. They may experience anxiety or have difficulties with executive functions, for example, planning and organising, initiating tasks and responding to unplanned situations. These challenges are common to many conditions, notably things like autism, mental health, learning disabilities, etc., and difficulties. So what Brain in Hand does is it combines the benefits of technology and the potentials of people's support networks to help them develop and deploy strategies to tackle everyday tasks and challenges. Designed for young people and adults with impairments of executive function, such as difficulties with planning, problem solving and initiating tasks, it helps them establish routines, deal with unexpected events and manage the stress and anxiety that can arise when things go off track. The application provides users with a step-by-step process of personal planning to help identify goals, pinpoint problems and develop solutions. And the proposal is primarily that we look to enter into an agreement for a 12-month pilot with the application for up to 20 people. Training on the application and its functionality is commenced, and the Adult and Community Services Department is working with social workers to identify a cohort of people to test the service and the effectiveness of the application. In addition to support on how to set up the use of the application, The cohort of the 20 people will also receive a personalised plan tailored to their personal requirements. This will vary depending on their goals and their support network, for example. A person learning skills to live independently might focus more on planning, reminders and prompts and be helped by a parent or a mentor. A young person wanting to manage their anxiety of using public transport might focus more on mood monitoring and strategies for dealing with unplanned situations. Each of the 20 people will co-produce their own support plan and strategies based on their needs, goals and skills with the help of a specialist who is always available. The support plans and self-management tools are easily accessible via a smartphone, a tablet, a website, which is complemented by human input. And help can easily be and discreetly be accessed when it's needed via a trained responder service, so help is always at hand. Further information regarding how Brain in Hand works is attached as an Appendix 1. And in regards to the risk implication, Brain in Hand implementation team will work with HBC staff to plan and support the best way of embedding Brain in Hand with individuals. This often takes between 6 and 12 weeks. A dedicated program manager will also assist the council throughout the implementation and for the duration of the pilot. Brain in Hand will provide regular data reports showing how the application is being used and help determine impact and value for money. It is a Tier 2 digital health technology under the National Institute of Health and Care Excellence and Evidence Standards Framework. The service is fully compliant with General Data Protection Regulations, GDPR, and is being commissioned by over 20% of councils in England, supporting hundreds of people across the country. The total cost of the council of implementing this pilot is around £28,500. This includes up to 20 licenses which can be reissued. Specialist support is provided as part of that deal, including individual annual response service, 3 program evaluation support days, and 4 project management support days. In terms of the legal consideration, the Brain in Hand pilot will be delivered through a 12-month contract, and appropriate checks have been undertaken to ensure that all relevant requirements are met. An exemption to contract procedure rules was obtained to allow this approach to be piloted. Consultation case studies were provided as part of the scrutiny into the service provider and reference checks with neighbouring local authorities. Child and family poverty. There are no child and family poverty considerations associated with this report. Equality and diversity. Brain in Hand demonstrates how assistive technology can complement services and shape service models to improve effectiveness, quality, performance, efficiency and value for money. The system is designed to put the individual in control of their own care in the centre of a network of linked support, therefore ensures people independence is maximised. The system can be accessed by people with a range of protected characteristics. Staffing considerations. There are no staffing considerations linked to this report. Additional training will be provided to support staff who identify individuals who may benefit from the Brain in Hand pilot. There are no asset management considerations linked to this report. Recommendations. It is recommended that Adult and Community-Based Services Committee note the contents of this report and receive a further report detailing the outcome of the pilot in due course. If the pilot is successful, there is potential to expand the approach to support an increased number of people. And the reasons for this recommendations is to ensure that members are provided with the information about the pilot and the outcomes achieved to evaluate its effectiveness and inform decisions about the future. And I'm quite happy to take questions, Chair.
Thank you, Neil. To me, I think hopefully this is going to massively work, especially for those who need it. I believe it's going to be an app on a phone where they can put what kind of day they're having and when they felt anxious and what they were doing. Obviously, this year, I think mental health has been raised so many times during the pandemic, and how many people have probably suffered more than what and never thought that did have mental health issues, like not being able to go to work, working from home. That has been not having when you're driving home from work, you're relaxed mode, thinking you've left everything back at work by the time you pull on your drive. All of that's gone. For the children who've And 1 minute they're at school, then they'll have to go back into 2 weeks isolation again, or when they didn't go back to school from March till September. That must have had a lot of negativity put on them. But hopefully with this new thing that's coming out, new technology, and I hate technology if anybody asks me, this is going to be so easy that somebody like me can use it, and it needs to be simplified. So hopefully you can say it is simple to use, and even I can use it.
Thank you, Chair. Yeah, it's one of a range of suites that both ourselves and our colleagues in health are looking to pilot over the forthcoming weeks and months, and we do hope it'll be a useful tool in the future.
Thank you. Stephen, would you like to come in?
Thank you, Chair. Yes, I think it's an excellent initiative, and look forward to seeing the outcomes from the pilot. But just a couple of quick points, Neil. Firstly, it is app-based, and does that app require a sort of like higher-end type smartphone? And if that does, is that possibly going to exclude some people who maybe can't access that financially, and what can be done to get over that issue? Second point is around how are we engaging with and identifying people to become involved with the pilot, and how are we getting that message out? And the third point is looking ahead, and if the pilot is successful, the current cost is, I think you mentioned somewhere around 28,000. And what sort of cost would be involved in extending that offer out to a wider group of people? So if you can sort of like give some information around those three areas.
I'll do my best, Stephen. The first question in regards to the application, there is probably a limited additional cost to users in relation to the use of the app, in a sense that they might need a mobile network connection. Primarily, it's not seen as too cost prohibitive. I think when we spoke to the organisations, they said it's never prevented anybody from using the app previously. So you're talking about pennies a month more. It doesn't need you to constantly have access to broadband. It kind of does a daily update periodically, and then uses just your mobile phone, the information stored on your mobile phone, to then prompt you to alerts, to calendars, etc. The only time I think that you use the broadband connectivity is really when you're downloading or uploading information that's been put in during the day. So it's like almost like a docking system, if you like. Initially, there's also there will be a need for you to have obviously the phone to be connected to the telecommunication systems, because there are safeguards in place should an individual require a physical response. They're able to call and summon somebody using the phone, and it's the app that kind of monitors their well-being and can alert them via a phone to a trained professional. The second one, in regards to how are we promoting this, we've initially held a series of conversations with the provider and a number of our team managers across the council, who provide support to probably about 6,000 people across the council presently, and asked them to consider individuals who may benefit from this. We will also be happy to take any referrals from any voluntary sector organisations, etc., should their need arise. We've obviously raised the profile at our mental health forum to those providers very recently, and there'll be more information hopefully following in the new year when we get our first cohort signed up. In relation to rolling out the pilot, there's always been a proposal to look at the 20 and as a pilot, with a view to, if it is potential, an opportunity that people can take out individual contracts, if you like. So it could be done through direct payments moving forward as an alternative. What we hope to achieve from the pilot is to look at the cost benefit of this, to say, whilst it's not there to replace personal care, to around improving independence and creating less of a reliance on paid support. So it could be seen as a cost benefit if we roll out.
I think also maybe we should mention somebody might find it easier talking to a device than talking face to face or texting somebody, because then you have to, there's somebody going to respond to you. If somebody's not going to initially respond to you straight away, obviously it's all going to be when you download it. I think you might be more truthful with an app than with. So hopefully that might prove right or wrong. I don't know, but hopefully this will help a lot more people with the feelings and anxieties and how they're going to get around things, like help them to get on the bus or on the train, or if they have to go shopping. And like, let's face it, my mum hasn't been shopping since March. And it's now 9 months. She's probably just used to giving me a list. I bet there's many of yous going shopping for elderly parents or vulnerable people in your community. But when it comes to, and I'll tell you the God's honest truth, I don't even think she can walk around Morrison's or Asda or Tesco's now, because she hasn't walked that far. So hopefully Gemma's bit would help people at muscular wastage. But hopefully I think a lot of people be more truthful with this kind of technology than what they might be texting or telling somebody, because they can always lie. I know you can always lie in an app as well, but people might be more truthful with the feelings going forward. So, Carl, did you want to say something? No. Your hand was up and it went down.
Sorry, Neil's answered the questions that I had.
Right, that's okay. We note that I'm really looking forward to, and if we could have some some case studies in the next report when you bring it back to us. Hopefully we might have it in March. Fingers crossed. Yes, no. But it's to note the report, and I think all it leaves us to say is Merry Christmas, everyone. Sorry, it's 20 to 1. I'll go on, Carl.
Just a small one, just on sort of any other business, really.
Yeah.
Our next planned meeting is in March, did you say?
No, February. I've asked for one to be in February.
Well, whenever it is, I would hope that we could possibly, and I know it's difficult with COVID, but I would hope that we could have some kind of a meeting to discuss the sort of proposed budget that would have an implication on adult services.
The precept.
Yeah, something like that, yeah. We need an input from adult services into that budget proposals.
Yeah, I hate money, but yes, I think I'll speak with Jill and see when if she can pencil one in for us. I was thinking about February, but if she wants to bring one in sooner, I'm quite fine with that. We have got the budget to consider, and that's so if Jill wants to come back on that.
It was just to say we probably need to seek a view from Chris Little about sort of the budget process and timescale and how that fits with Finance and Policy Committee meetings, but I can pick that up with Chris if that's helpful.
Thank you, Jill. Stephen, did you want to add anything there?
Yeah, just to follow up from what Jill said, and the normal process would be that the budget proposal would come back from Finance and Policy to all of the service committees before going finally to Council. So I think if perhaps we try to follow that process then as closely as we can, then we should cover Carl's point, I think, which is a very good one.
Yeah. It's just, everything's just, it seems, you don't get to see people and you can't ask these because we're all remote. One of us could be in Abu Dhabi now. We're not, but wishful thinking. But we're not all in the same room where little points like this would be mentioned behind closed doors. But I would like to wish you all a Merry Christmas. I know Boris doesn't want us to have too much family around us. I'm not going to tell you what I'm doing, but because it's recorded, so I'm going to shut my mouth. Merry Christmas, and I hope we all have a better 2021. It can't be any worse than 2020. So thank you for attending today, and I'm so sorry for blabbering on too much.
Okay.
So Merry
Thank you,
Christmas.
Chair. Merry Christmas.
Okay.